Good morning, good afternoon, good evening, everybody. And thank you for staying with us again. And I hope you had a nice break. Okay, before we go further, a couple of housekeeping items again. As I told you, this workshop is being recorded and the recordings are going to be available within 24 hours. If you have any questions, please put those questions in the QA box below. On-demand materials will be available in the resources area. Again, important, in case there's a platform outage, any technical issues, we will be sending you email with a backup platform where we will continue these proceedings. And finally, please follow Critical Path Institute on social media, LinkedIn, Facebook, Twitter, YouTube. And if you're going to be posting about this meeting, please do not forget to use the hashtag IN2020. And the next item on the agenda is racial and health equity in neonatal clinical trials. And I'm going to hand it over to Deb Discenza and Jennifer Degl from me. Deb, Jen, you're on.
Thank you. Hello, everyone. I hope this finds you well. It is an honor for us to speak to the racial and health equity in neonatal clinical trials. This is a very important topic, always has been a very important topic. You will find that we have some very brave speakers talking to you today, some parents, some professionals. We are in an unprecedented time in our history, but as you will see, this is not the first time we've had racial and health inequities. History says so, and here's why. In the 1800s, gynecological experiments were carried out on enslaved women without anesthesia. 1930s, I'm sure you've heard, if you've not heard, Google the Tuskegee study. It's a very long history, basically the not treating Black men who have syphilis, not treating them when there was a treatment available. Many of them died. In World War II, the Black soldiers were used as guinea pigs in chemical experiments. In 1951, Henrietta Lacks had tissue samples of tumors taken without consent during her surgery that was put into medical research that's used to this day, again, without her consent, her family's consent. And you would think, okay, well, maybe we've righted some things by now, but we have not. We are looking at 2020, and there was recently a study about Black babies being under the care of white doctors. They had a higher likelihood of death than they would under a Black doctor. That speaks to me. I actually formed the Alliance for Black NICU Families this summer. I'm a co-founder. I've been hearing all sorts of stories, and I'm looking forward to speaking to that issue today with our panelists. I will speak to the issue of trust, and then my co-chair, Jen Degl, will speak to the area of access. In terms of trust, Tuskegee, there was an apology by President Clinton in the 90s. That matters, it's important, but it's the actions that speak louder, especially with these families in the neonatal intensive care unit. And what have we done to show that honesty and show that trust? Look at the history slide I showed you before. It speaks loudly. Those are the actions that speak loudly. It's concerning. So when a race is given everything and the other side is just taken, they just take. Why? Why would they want to volunteer for something? Why would they be willing to do that? So think long and hard about that. There has to be a give and take. It's a real relationship with real trust. I heard that in the first session numerous times talking about trust. Well, this is a trust that's been broken again and again and again. Has to stop. For what we're trying to do to succeed in clinical trials, when I'm hearing about the COVID-19 vaccine trials being stopped because they did not have enough African American and Latino participants, this is a real problem, and it affects our area too. Jen Degl, my co-chair, will speak to access.
Thanks for being here this afternoon, everybody. I'd like to talk to you about 2 quick stories and then ask you some questions before we move on to our panelists. The first story is my story and my daughter's story. Not long into my pregnancy with my 4th child, I learned I had an advanced case of placenta accreta after I hemorrhaged and almost lost my life. Each hemorrhage that followed was worse than the previous, but I had exceptional medical care and was able to remain pregnant until 23 weeks gestation when I delivered my daughter, Joy. Joy was admitted into the NICU, where she also experienced exceptional medical care for 121 days, which included 1 clinical trial during her stay and 1 that lasted 1 year post-discharge. For this trial, my husband and I had to take her to Columbia Presbyterian Hospital in New York City from our home once a week for the first few months, and then bi-weekly for the remainder of the year. We live about 50 minutes north of New York City. Participation in this trial improved Joy's quality of life. We were able to participate in the trial because we could afford for me to take a 2-year leave of absence from my job, and we could use the COBRA part of my health insurance, which was excellent medical care at the time. We were able to drive the 50 minutes to New York City and pay to park our car, and we could afford the gas. We were able to pay a babysitter to watch our 3 other children while we traveled to the city to allow Joy to participate in that trial. My daughter is now a healthy and happy 8-year-old who only lives with 1 negative byproduct of her extremely premature birth, and that's bronchopulmonary dysplasia. I now want to introduce you to Richard. Richard was born to a single Hispanic mother who did not speak any English. He was born with an omphalocele among some other heart defects. Richard had already been in the NICU for 5 months before my daughter was born. Richard's crib was right across from my daughter's. Richard's mother and older brother, who was only 4 or 5 years old, were not able to visit on weekdays and would only arrive on a Friday afternoon and come back and forth throughout the weekend. Richard's mother had to work a full-time job and then take a train to the bus to get a cab to visit him in the NICU. Richard's mother would pack a cooler of food for her and her son each Saturday and Sunday, as they would be spending most of the weekend at the hospital. Richard's mother declined the opportunity to enroll him in a clinical trial that would require him to visit a rehabilitation hospital after discharge. So before I put you on to the next panelist, I want you to think about a couple of questions. What are the big differences between these 2 babies? What access barriers exist that hinder efforts to increase minority participation in neonatal clinical research? And what can be done to overcome these barriers so all races of neonates are equally represented in clinical research studies? I would now like to introduce you to Gigi Kanyanga Fernandez, who is a very close friend of mine, and she has an excellent story to tell. Gigi?
I hope I can live up to that, Jen. Thank you, everyone. Let me just see. I was born in Tuskegee, Alabama, 2 years before the infamous syphilis study ended. And not only did I continuously hear about the study growing up, but our family also knew several of the people and their families who were a part of and were affected by this study. The U.S. Department of Public Health and CDC called them, quote unquote, test subjects and viewed them as they were objects and they were disposable. But we knew them as Mr. Pollard, Mr. Shaw, and even my maternal grandmother's relative, Mr. Hawkins, who had families, hopes, and dreams. They were people and they were valued. People whose lives and the lives of their families and the descendants, as well as the trajectory of the entire community, were permanently altered due to racial indifference, aggression, and discriminatory clinical practices by supposedly reputable, trusted, and predominantly white institutions. Research and clinical trials are a part of the fabric not only of the Tuskegee community, but beyond. there still remains the strong suspicion and belief that researchers use clinical trials as a facade to kill, destroy, and maim. Tuskegee is a symbol of clinical racial abuse, but it's not the only one. Deb mentioned Heredity Lax, Planned Parenthood. There's so many to name. But these trials are an example of this quote: "One lie is enough to question all truths." Now, although I left Tuskegee many years ago, and I've lived and worked and traveled to several states throughout the U.S. and countries, and I currently reside in London, England, the impact of Tuskegee still lingers. This study, like so many others like it, assumes a lot. Assumptions that solely benefit and justify the researcher and not the people who are being researched. Assumptions that continue to this day and that were projected onto me as a brown-skinned mom in the NICU. Despite my own professional background in healthcare and my ability to advocate and articulate my needs, I still intuitively felt and had to fight off all of these silent assumptions that I encountered during our NICU stay. Now, we were in the NICU for about 6 months, and we were watching our surviving 24-weeker daily fight for his life. And while we were there was a clinical trial being done in our NICU around the relationship between formula, cow milk sensitivity, and NEC. The consultant neonatologist leading on the study saw me every day in the NICU with our son, and she never spoke to me. After about 2.5 months into the NICU, into our NICU stay, she spoke her first words to me after our son developed NEC, had a colostomy and a resection, and was now deemed a great candidate for her study. Prior to her charm-offensive beginning, her apparent belief was that I nor my son were as important. Every single day during rounds, she saw me, looked me in the eye, and did not say a word. And this was even more apparent because the other consulting physicians did speak to me. When she finally spoke to me about her study, she was surprised that I was, in her words, educated and articulate. Why? Why did she say this? Although she didn't verbally explain herself, her actions and words reflected her belief of an historical picture and an often common, unchallenged, and proofless assumption that I have frequently experienced, which is, as a Black person, you're ignorant, uneducated, and unintelligible. She was looking for something to confirm her beliefs. Now, her misconceptions of me continued when, after I said I would consider participating in the study, she assumed this meant yes. And frequently, over a couple of weeks, she would enter the NICU and make a beeline to me and inquire whether I had completed the forms and completed and signed the forms for the trial. She had not listened. I said consider. She heard yes. This is a common occurrence for Black NICU parents. They are often not heard, even when they speak. When I began to ask questions and for clarification about the study, its purpose, outcomes, possible side effects, etc., her position became partly patronizing, partly authoritative, and definitely less charming. She did not expect me to engage with her in such an autonomous manner, and I was showing up in a way that did not fit her historical picture of a Black person or NICU mom. And her negative responses to me was really poisoning any possibility of me allowing my son to participate in the trial. Now, not surprisingly, her assumptions and misconceptions led to this huge distrust between us. Even if the study were an important one that would benefit hundreds of babies, the trust was not there. In fact, it had never been established. It had been assumed by her. This led to a huge expanse and distance between us that caused me to question, as a mom, whether my son would be discriminated against in the trial. Would all of these assumptions and perceptions and behaviors that I'd experienced would somehow seep its way through her handling of his details and his information. Now, I know this sounds a little bit far-fetched because given that trials should function off of anonymity. I knew I'd get tongue-tied on that. But nothing about her demeanor or words as a clinical researcher proved to me otherwise. She was the lead, and she could influence the nature of the trial. And this made me not only less likely to participate, but it also led me to discourage other NICU parents from participating, particularly those of color. As NICU parents, we're already fragile as it is. And often we're kind of going on this pendulum between the life and death of our children while we're in the NICU. We often don't have the energy or the desire to deal with an extra layer of uncertainty as it relates to our child. And really, in some ways, that's what a clinical trial is. The distrust I had with our consultant and the concerns around participating in the trial she was leading could have easily been mitigated if certain things were changed. Now, I started my brief talk with you today, highlighting a racist and unethical clinical trial that has cast a long and ever-present shadow of toxic distrust of research and studies within my community of birth, but also across the USA and globally. We cannot underestimate the power of this shadow in medical research today. In my previous work as a senior healthcare professional across several states from the East to West Coast, I frequently came across this shadow. And I saw it in the uneasiness of Black people when they had to interface with the largely white or non-Black medical staff. They weren't comfortable with trusting them, but equally they felt like they didn't have a choice. Today, I briefly shared a personal story of the racial inequality that I experienced within the clinical trial while we were in the NICU. And although this is an incredibly complex, multifactorial, and sensitive issue, racial and health equity is a concept that can be changed. But it will take more than a panel discussion about it. It will require clear and transparent action. Arnold Glasgow said, an idea not coupled with action will never get any bigger than the brain cell it occupied. And basically he's saying, if it stays in our heads, or if it stays in our conference today, in this conference today, and doesn't go further, it's meaningless. So I want to leave you with a few tips that you as researchers, as audience members can begin to consider to implement to help you begin to pivot to make equitable changes in your trials. I won't go through all of them, just hit a few. The first one is be willing to change. Otherwise, why bother? Second, implement continuous unconscious bias training. And this can't be a one-off tick box exercise. We all have unconscious biases. And as researchers, you need to know what yours are and how they may influence not only the setup of your trial, and most importantly, the interpretation of its results and usage of its results. Third thing is start on an equal and level playing field. I think this is actually the most important one. Recognize that both entities, the researcher and the NICU parent, are offering and receiving something. The former offers scientific expertise and receives meaningful data and information of the parent and child's lived experiences. But the NICU parents offer their children, and this is priceless, as well as their parental expertise, and they may receive a small monetary gift, parking, and a lot of thank yous. Fourth, be honest, empathetic, inclusive, and transparent. I suppose these are self-explanatory, but show parents this Lastly, exhibit active, compassionate, and respectful engagement and listening. I say this a lot to those of you who know me: listen to hear and not to respond. I can't stress that enough. But key point here is engage with parents before you want them to participate in your study. Don't just interact with them when you want something from them. A simple hi or desire to get to know them and their story before you want something from them cannot be underestimated. There are many more steps we can think about and taking, but I hope that these few will help you begin to think and start to make the change to make sure your culture and mindset of racial equity is embedded within your organization's research and research practices. Many thanks for your attention, and I'm now going to turn you over to Janae Johns, who's a fellow preemie mom and founder of Once Upon a Preemie Academy, who will share her experiences. Janae?
Thank you, Dee, for that wonderful introduction and a very timely and important overview of health and racial equity as it relates to clinical trials and African Americans in the United States. Again, my name is Janae Johns. I bring you greetings from the city of Philadelphia, state of Pennsylvania, where a number of wonderful pharmaceutical companies have headquarters and often attempt to reach inside the walls of the Philadelphia community to lead various clinical trials in the African American community. I, like Gigi and my other colleagues, Deb and Jen, am the mother of a micro-preemie miracle. My son was born at 26 weeks, weighing only 1 pound, 15.3 ounces. We had a long and arduous 77-day journey through the NICU, in which my son was born during one of Philadelphia's worst snowstorms. And among many other challenges that we experienced during our NICU stay, at discharge, he still had fairly fragile lungs. He had bronchopulmonary dysplasia and still has to this day. As my colleagues have already shared, NICU parents face a sea of emotions upon entry, during, and at discharge. And unfortunately, these emotions don't leave us or flee once our children graduate from the NICU. Of the emotions on this word cloud, I'd say the fear, the anxiety, and the trauma leaves many preemie parents and micro-preemie parents feeling hopeless and uncertain about their child's fate. And because of that, it becomes extremely impossible, completely impossible to wrap your minds and hearts around being approached by neonatologist or any clinician or any researcher in the NICU when your child is so small that they can fit in the palm of your hands to talk about participation in a clinical trial. While my colleagues have already referenced many historical medical mishaps that have caused and left historical and long legacy stain and harm in the African American community as it relates to medical experimentation and clinical trials, these things are embedded and ingrained in us at birth and for a lifetime. And so to sit in the seat of now being a parent of my first child, knowing that this historical harm has happened and continues to perpetuate itself, it was very difficult for me to want to excitedly say, yes, please sign my son up for a clinical trial upon entry to the NICU. As it continues to be difficult to be completely transparent as he continues to grow up, and we are often contacted to ask if we want to participate in clinical trials based on his BPD, based on his prematurity, and based on some of the feeding challenges that we've experienced, because the fear and the anxiety and the trauma revisits 6 years later. And you never want to be in the seat as a parent, especially as an African-American parent, feeling that my child may receive the placebo effect and they need the actual medication or drug. As Deb and Gigi have referenced the Henrietta Lacks story, this story of this 31-year-old African-American mother who had cancer and cells were used unbeknownst to her and many years to her family sticks with me for many reasons. This photograph is a Googleable image of Henrietta Lacks and her cells. And the other photo is myself and her descendants, her grandson, great-grandson, and great-granddaughter, who are still in the Baltimore, Maryland area where she was from. And we were participating in a conference about 3 years ago about minorities' participation in clinical trials. And we learned that day that Henrietta's descendants are now a part of the National Institutes of Health clinical research board that helps to approve or not approve which researchers or clinicians or organizations have access to Henrietta's cells to continue research. There's still lots of question and uncertainty around any remuneration or compensation that came back to the Lacks family's descendants with her cells being utilized without her permission. But that just brings us to a point that Gigi raised that continues to play true in a lot of African-American families' hearts and minds, NICU and non-NICU. Will my cells be used with or without my permission? Will I die if my cells or any parts of my body are used with or without my permission? And then what will happen with my family as a result of it? These are all very important questions, and these are all still very valid, especially in today's climate where African Americans continue to experience the highest rates in this country of COVID disparities, prematurity disparities, maternal and infant mortality, morbidity disparities. And these issues are not always due to personal decisions or choices. They are issues that play out at the clinical and systematic systems level at a systematic and discriminatory way, so much so that the American Public Health Association has recently called racism a public health crisis. And so knowing this historical hurt and harm that has already happened in our community and continues to play out in COVID and other ways, I ask you, as researchers and as clinicians, and even as preemie parents on this conference, what will we do to ensure that we're removing as many barriers to engage the most medically vulnerable and the most medically deserving communities that have historically and continuously experienced discrimination and disenfranchisement? This infographic encourages us to look at the roles that we can play with, yes, ensuring that everyone has access. Well, clinical trial is the access that we all in the United States and beyond may have access to. Where if we're talking about applying an equity lens to that clinical trial, if we know that for certain communities and certain populations, there are way too many barriers, mental, emotional, historical, financial, socioeconomic, political, or other, what will we do to be liberated as a professional and clinical community to help ensure that all populations and all communities have the full opportunity to fully participate and engage in a clinical trial? I encourage you and I challenge you to think creatively and beyond what has already been done and that may or may not work well for your clinical trial to engage minority populations. I have had several career experiences and opportunities to help researchers and clinicians think creatively about engaging minority populations in clinical trials. And a lot of these strategies honestly involved building a trusted relationship, building a rapport well before the clinical trial need appears. And so for a lot of organizations and a lot of companies, that meant going inside the walls of non-clinical environments to engage lay health individuals in these clinical conversations, visiting churches, visiting nonprofit organizations, visiting parent civic associations in communities and in environments where we know the populations are the least likely to want to participate and engage in clinical trials because of historical trauma and distress. Most recently, I've created the Once Upon a Preemie Academy, which is the first of its kind and unique health and racial equity virtual training academy for the perinatal and neonatal community. We will talk about issues and barriers faced both at the clinical and non-clinical level for families to engage and participate and care for preemie families and babies. And in time, I know that we will get to a place where we will have solutions and strategies that work for everyone to fully participate and engage and feel empathy, respect, and trust in and outside of clinical trials. Thank you. I would now like to transition our time to my colleague, Wakuku Lukulid. Thank you.
Thank you so much. I hope you can all hear me and see the slides. This platform is definitely my first one to try. I appreciate Deb and Jen for including me in this session. Health disparity in perinatal space definitely exists. I'm a neonatal nurse practitioner. I have been for 18 years. I practice in Nashville, Tennessee, which is a South. I have been an RN since 1991. I was transplanted from Japan, where we really do not have the same type of racial differences. Just about everybody who lives there is Japanese. But from my perspective of being a foreigner, observing the U.S. Phenomena, so to speak, I wanted to just say a few words, but mine is going to be very short. My very first awareness was that breast cancer happens in both white and Black women, but for some reason, mortality is 40% higher for the Black women. I was diagnosed when I was 36 years old, and that struck me. And I have some graphs. I'm going to skip a few of this. Pregnancy-related death between 2007 to 2016, U.S. overall is 16.7 per 100,000 birth. However, for Black women, it's 41 compared to 13 among white women. That's a huge disparity. Infant mortality rates by race and ethnicity, 2018 shows, I know this may be a little small to see, but Black infants' death is definitely twice as much than the white infant's death per 1,000 live birth. Preterm birth rates in percentage in 2018 also shows racial disparity. Among the Black infants, 14%, and among the whites, it's 9.1. Actually, in Alabama and Louisiana, this number for the Black infants is greater than 17%. So there is such a disparity. When there is a disparity, do various groups of patient groups, do they ever really feel that they are cared for in the exact same manner? That would impact the trust that they develop or not develop. If you ever ruin one relationship, and I know it's a hard act to follow, these two ladies that spoke from their own experience of having lost trust even before one conversation occurred. If you ruined one relationship, how long would it take to regain that? Or have you lost them forever? So I mentioned that growing up in a culture that racial and ethnic differences are not really prominent made me see that if you grew up in an environment like that, it does wire your brain differently. So that leads to the unconscious bias. So I think it is very important. I'm sorry, I didn't mean to go. Acknowledge that both implicit and explicit personal biases that really exist. And I think we have to really think hard about the trust relationship. Recently, 6 recommendations came out from Vermont, Oxford, to actually, it's titled Our Responsibility to Follow Through for NICU Infants and Their Families. And it actually speak about what we must do, not just to fix their physical problems in NICU, but to follow through so that the psychosocial issues and such can be addressed. But this recommendation, the first 3 especially, I believe is highly relevant for the clinical trials. Promote a culture of equity, identify social risks of families, and provide interventions to prevent and mitigate those risks. Those are some things that we heard from these ladies, Gigi and Jenny. If they have some risks that we observe, we must make sure that we intervene to help and mitigate so that we decrease the barriers against being able to participate in clinical trials, even if they really want to. There may be barriers, just like also Jennifer mentioned. Take action to assist families after discharge, especially many clinical trials continue on after an ICU, and maintain support for families through infancy. And these are powerful, and you can easily access more in depth at their website. And I have some references, but this ends my presentation, and I will hand this over to Dwayne Persley from Beth Israel Deaconess Medical Center and Harvard Medical School. Thank you for the opportunity for me to speak.
Thank you, Akiko. I'm Dwayne Persley. I'm Chief of Neonatology at Beth Israel Deaconess Medical Center. I'm also the medical director here. And I hope that the sharing of experiences by our former NICU parents has shed some perspective on how racial, ethnic, and socioeconomic issues might impact their perspectives on participating in neonatal research. Building a cultural norm, that is the shared expectations and rules that guide our behavior for racial equity in NICU clinical trials, given our history and numerous obstacles, feels daunting. I'll state at the outset that my premise is that a necessary and impactful step is to first focus on the care we provide. What I'd like to do in the next few minutes is speak about the drivers of disparate health and well-being of preterm infants and families, some of the specific barriers these families confront, and the opportunities for intervention to build a cultural norm for racial equity in our NICUs. I had an opportunity to collaborate with Andy Beck, Erica Edwards, Jeffrey Horbarge, Liz Howell, and Marie McCormick to outline the causal pathways: increased risk, lower quality care, and economic disadvantage through which racism, segregation, and inequality adversely impact short and long-term outcomes. Non-Hispanic Black women and Hispanic women are at increased risk of preterm birth in the U.S. We know that these disparate risks, as well as the risk of infant mortality, are strongly associated with social determinants of health, defined by the CDC as conditions in the places where people live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. Some, like neighborhood deprivation, economic inequalities, educational disparities, and differential access to healthcare, with sequelae like nutritional deficiencies and unhealthy environmental exposures, are felt by many to be rooted in structural racism. The social determinants ultimately have biologic effects, but they don't sufficiently explain the excess risk. Genetics likely plays a role, but it's thought to be small, and it's manifested less as gene presence and more likely as gene expression. It's regulated through epigenetics or interactions with other genes. interventions to improve the quality of prenatal and interconception care, increase pregnancy intervals, assure access to 17-hydroxyprogesterone, ensure cerclage placement in high-risk women, and screen and treat specific infections have had mixed success in addressing the gap. Hopefully more understanding is forthcoming, but our current best hopes for intervention lie with mitigating environmental exposures and ensuring access to effective care. There are also differences in care quality. They may contribute to racial and ethnic disparities in a couple of ways. First, white and minority preterm infants may receive care in different NICUs, and NICUs primarily serving minority infants may have structural characteristics associated with lower quality or with organizational models or clinical processes that lead to lower quality care. In one study by Howe, 40% of Black-white disparity and 30% of Hispanic-white disparity in New York City was explained by birth hospital. The quality of care received by preterm infants can also differ by race and ethnicity in individual NICUs. Suffice it to say that there's evidence of both. In the first case, in disparate care delivered to babies, and in the latter case, in disparate support provided to their families. The inequities in both scenarios may be reflected in parental perspectives on participation in neonatal research. Finally, social economic disadvantages. The effects of social risks don't stop at preterm birth and infant mortality. Less appreciated is the fact that this risk extends beyond birth to influence later outcomes. Preterm infants who are born to low SES mothers at extremely low gestational age or very low birth weight, when compared with their more advantaged counterparts, at a greater risk of poorer health and long-term neurodevelopmental deficits. These infants are disproportionately exposed to poverty and adverse childhood events, and there's evidence that the adverse effects of these stressors can be buffered by interventions that reduce the effect of stress and foster resiliency. The result is greater attention to NICU to home transitions, and Dr. Smith will speak more on this in the next presentation, and to enhancing family caregiving skills with specific therapeutic and developmental interventions for the infant. We know that federal law and NIH policy mandate inclusion of minorities in NIH-funded research. Further, NIH-defined phase 3 clinical trials are required to report outcomes stratified according to race and ethnicity, unless data are presented to suggest that differences are unlikely to be observed. Despite our desire for equity and justice, given our frustration and lack of success to provide equal representation, are these and similar objectives viewed by sponsors, regulatory agencies, funders, medical journals, peer reviewers, and investigators met with variable expectations? There, of course, is a legacy, and that has been reviewed in previous presentations. The specters of Tuskegee and Henrietta Lacks, both highlighted in African-American literature and mainstream motion pictures, remain. These memories are compounded by racism, alienation, and exclusion, top of mind in the current year. There are other barriers as well, including poor health literacy, lack of information, language barriers, limited accessibility, and implicit biases. The cost of trial participation may be formidable. Direct costs like fuel, parking, meals, lodging, and indirect or opportunity costs like missed work. Finally, the lack of diversity on research teams may limit perspectives on effective communications or further perceptions of being experimented on. The Pew Research Center has documented that Black and Hispanic Americans are far more likely than their white counterparts to say that scientific misconduct is a big problem. They are more hesitant to trust medical scientists, embrace the use of experimental medical treatments, And then in the case of COVID, sign up for a potential vaccine to combat the illness. Finally, in pediatrics, despite a growing consensus that addressing social determinants is essential to improving population health and ending health disparities, there's been sporadic uptake of health provider screenings for the unmet social needs that can affect early childhood health and development. And this is certainly true of our NICUs. These are the family provider touch points through the early life cycle that offer opportunity for improved engagement, care, and potentially clinical research engagement. For the NICU, the opportunities begin well before admission. While there may be mistrust of scientists, Americans in general trust their practitioners, generally viewing medical professionals favorably. When possible, engagement and enrollment operated in the context of the obstetric office provides a sense of assurance that is difficult to obtain during a hospital admission. Even so, working in concert with obstetric programs and personnel after obstetric admission may be a useful entree. An introduction by an antepartum nurse or maternal fetal medicine provider may be more effective than a cold call by a member of the neonatal trial team. Practicing social as well as technical medicine, NICUs can embrace responsibility for the care of NICU infants and families beyond their walls through culture and practices that intentionally address the needs of families at social risk and set the stage for a more effective clinical research engagement. Finally, collaboration and coordination with the pediatric medical home and NICU graduate programs will better serve families and improve continued follow-up in clinical trials. As stated by Horbar, it is our responsibility to follow through and address the social determinants of health with the same energy and expertise that we devote to the technical aspects of the care we provide. I would add that the same philosophy and vigor should be used to ensure that the families of our babies at medical and social risk are better informed about and have improved access to the benefits of clinical research participation. I do believe these principles are intertwined. The more we are aware of and attend to the social needs of our families, the more success we'll have in establishing the relationships and trust that mark successful trials. Here are a few approaches. In promoting a culture of equity, there are several approaches to promoting this culture. Some units have initiated curricula to support cultural awareness and sensitivity and manage implicit and explicit personal biases. Some have touted nurse-led rounds focused solely on the family experience. Screening for social determinants, even while the infant remains in the hospital, allows for interventions to be in place at the time of discharge. This includes mental health counseling and assistance with housing, meals, and transportation. Some NICUs have employed legal assistance to help with issues common to families living in poverty, issues involving substandard housing, public benefits, and partner violence, among others. Families need teaching and support to have the competence and confidence to leave the NICU environment and provide care after discharge. Home visits and assistance through mobile health and social media can be useful adjuncts. Facilitating reconnection to contraceptive and family planning services can be done before discharge. Parent coaches have been shown to be effective in family integrated care models. Families can be mistrustful of home visits, including for evidence-based programs such as early interventions. And NICUs can play a huge role in better educating and preparing families about the benefits of these programs. Utilizing standard models, quality improvement can be applied with an equity focus, with attention to disparate structure, process, and outcome measures. One qualitative analysis revealed examples of inferior care, including neglectful care, judgmental care, and systemic barriers that were disproportionately experienced by families of color. And finally, advocacy is necessary to ensure that our healthcare organizations accept and act on their responsibility for the populations and neighborhoods that they serve. Eliminating health disparities requires partnerships with communities served by health systems to help guide, design, and implement strategies. So clinical care and clinical research trials are strongly intertwined in our academic NICUs. The attitudes, philosophy, and culture with which we approach our patients and families impact the way we care for them. Equitable approaches to care quality will extend to the successes of improved equity in clinical trials. We need to leverage and extend the trust in clinical providers to their clinical investigator colleagues. The challenges are daunting and the approaches vary. Most important is to start someplace and to start today. And I'll now pass you off to Dr. Vincent Smith, who's Division Chief at Boston Medical Center in the BU School of Medicine.
Thank you very much. Dwayne talked a lot about what happens in the NICU and how we care for families in the NICU. My work is on the transition from the NICU to home. And so my area of my academic focus is how we help families get ready to take their babies home and continuing to care for their babies at home after having been in the hospital. And so a few definitions that I have to throw out because of my research is NICU discharge readiness is the primary caregiver's masterful attainment of technical care skills and knowledge, emotional comfort and confidence with the care of their infant. NICU discharge preparation is the process of facilitating discharge readiness, meaning that discharge preparation is the process and discharge readiness is ultimately the goal. And so I tell you this so you can kind of understand the framework that I'm going to use to kind of have our discussion today. And so a few insights from working in this discharge preparation area is that, as Dwayne really expertly laid out for us, the NICU strives to create a culture of equity. And in general, staff tend to do an amazing job. We've heard from Gigi and from Janae that sometimes that's not true. So even though ultimately the goal is to do an exceptional job, sometimes it doesn't happen. And so what is true from this work is a few more insights is that sometimes families can observe differential treatment by the staff, even when they don't mention it to the staff. A classic example is when Gigi was talking about the consultant who never actually spoke to her till she wanted something from her. And it was obvious that other consultants interacted with her in a different way. And so when families notice that there's a differential treatment, even they feel insulted, as well they should. And even when they don't share those insights to the staff, they are still, internalizing those messages and those feelings. And as Janae mentioned during her presentation, is while families are in the NICU, they often have a lot of anxiety and trauma just from being in the NICU. But also, as we learned from earlier in the presentation, a lot of families are coming into the system already having had negative interactions or having a family history of negative interactions with the healthcare system. And so that can also lead to these prior negative interactions can leave some families with a heightened sensitivity for perceived slights. So when they do notice this differential treatment, it's much worse than if the family didn't already have some maybe negative connotations with the healthcare system. And one of the really important points, which I think you've heard kind of throughout everyone's presentation, is much of the family's experience is shaped by interpersonal interactions. So the one-on-one kind of interactions are really leave a lasting impression for what the NICU experience means to people. And so what I would like to do is kind of take some of these insights and extrapolate that to research. And there's kind of a couple of ways to do that. So the first way is thinking about the individual family that you enroll in the NICU. And the other way is to think about kind of globally, how do you change a culture or a system overall, so that by the time that you get to an interaction with the family, that it's not negative to begin with. And I'm going to focus a little bit more on kind of the global perspective, like kind of extrapolating out into the world, as opposed to focusing more specifically on the interactions in the NICU. And so I would say there's kind of three areas that you really want to focus on: making the work or the research relevant, and then building trust and getting people engaged. And so I'm going to explore each of these three topics in the upcoming slides. So the first thing is make the work relevant. And so when you're doing research, or when you're thinking about doing research, and especially if there's a topic or a community that's going to be more affected, or if affected at all, like, do topics that really have meaning for those communities. And this is incredibly important. Like, when you're doing the work from the beginning, have the communities that you're interested in working with be part of the work from the beginning, and have people involved in every aspect of the work. Because then a lot of the implicit biases that you've already heard mentioned earlier, those they don't get played out as much when you have a wide range of people sitting at the table and involved. The next is how to build trust. And you heard Janae actually mention this a little bit earlier in her presentation, is you have to engage people. You engage community leaders, institutions, groups, clinics, clinicians, and she mentioned nonprofit groups, which I didn't throw in there. And then you go to the people as opposed to having them come to you. Go to their churches, go to their community center, go to their schools, talk to them, find out who they are, what they're about, what things are important to them, and then hire people who are actually from the community that you're interested in working with to be part of your team. And so if people see people that they know and they recognize, people who look like them, people who live like them, they're much more likely to give that trust to those individuals, as opposed to people who don't look like them, don't talk like them, don't dress like them, and don't act like them. Next, how do we build some trust? Trust takes time, and you heard that mentioned earlier as well. And so you've got to spend some time, facilitate community support, and spend some time in the community building some credibility. Because once they believe that you really have a sincere best interest at heart, people are more likely to trust you and to get on board with you. And have a genuine interest in the community. If you're there purely because you want something from the community, or because you need a certain category of people to complete your research, that's going to be really obvious. And people can smell a phony from a mile away, and they're never going to trust you. And so invest in the community and beyond just that project, because otherwise it seems like you're just trying to use the community to get what you need from them. And if you're going into a community, that, like, if you're going to be doing work with the community, you're not going to be doing a project, give something back to that community, help build some infrastructure that will continue on even after this research is done, because then the community has actually grown and benefited from this work and this interaction. And the best way to figure out which way can help the most is listen to some of the challenges that people in the community are facing, and come up with some real solutions that can actually help with the problems that they're facing. Next is how to get people engaged. Incentives are really important. And I think it was Degl who mentioned parking. So ethical incentives can be a little tricky, because what you don't want it to be is coercive. So you have to be really thoughtful in how you give incentives to make people want to behave. And next is recruitment and advertising. And I'd say hire some community people as consultants to kind of inform your marketing strategy, because they will understand what the needs are of the people. They will understand how to speak to the people. They will understand the language that the people, they understand the terms and the terminology that people will understand. And so you'll be speaking their language in a way that they understand. And then have some educational sessions in the community where you're not actually trying to recruit. What you're actually doing is you're trying to raise people awareness about the issues and and about the challenges and problems that you're going to be doing the work on. And last thing is using a multimedia approach, because that's important. If you only rely on one specific way to get the message across, it's not as likely to be as successful. So our next steps are going to be Deb and Jen doing our panel discussion.
Okay, I'm sorry. Okay, thank you, everybody. Hopefully you can see the screen. That was a fabulous presentation. Really, really thankful to everybody who participated. Some very amazing and very personal stories. So we appreciate everything that was shared and all of the recommendations that were made. So what are our next steps? After everything we've heard today and things that we are now thinking about, I would like to invite you to think about what we can do moving forward. So we have a couple of next steps listed here, and there will be a poll in a few moments that Deb will introduce. But is there a possibility of the INC creating a racial and health equity work group? Is there a possibility of the INC being able to create guidelines on racial and health equity to provide insight for each existing work group that already is working hard every day? Or are there other ideas that perhaps some of you would like to share with us in the questions or comment area? So with that, I'm going to pass it on to Deb.
Okay, so there's a survey that should pop up onto your screen. With I think it's 2 questions, if I remember correctly. Do you think Inc. should form a racial and health equity work group? Could the team handling this presentation tell me how long it would take results? Okay, here we go. We'll give it another 30 seconds or so. And while we're doing that, I want to thank all of our presenters today. They were phenomenal. I wish we could all give you a standing ovation. That's how impressed I am. It was so heartwarming to know that you felt comfortable enough to talk about the issues at hand, Gigi and Janae. Jen and I got emotional. We all were getting emotional. So we just want you to know we're very proud of you and we stand with you. Okay, so we're still getting, okay, so our results start finishing up. And I'm going to try and, I guess I can go ahead and send this to the audience if I remember correctly. So, all right, people are still voting. So if you're going to vote, get it done now. And then we'll move forward with questions. Nope, still getting more people. Results are very interesting, by the way. Okay, I'm going to send it. Oh, no, someone's still voting. This is a very enthusiastic voting group. I like this. Okay, so here we go. I'm going to send it. You should see it. 92.1% said yes. You should do that. Very cool. Very impressive. We have several questions that we want to put to our panelists. So do we have our bridge up with our group? I assume we do. Jen, do you want to do the first question? Number 31.
Okay. Yeah, sure.
Oh, I'm sorry. Number 30.
Sorry, it's first time in the platform. Okay.
Yes.
What approaches, this is for, let's see. Okay. So what approaches can we use to tackle and improve understanding of implicit bias that influence clinical trial enrollment? So nicely highlighted by Gigi. So do we have a particular panelist that wants to take that question? What approaches can we use to tackle and improve the understanding of implicit bias, highlighted by Gigi?
Since they said my name, I guess I'll have to take it.
Okay.
And by the way, this is from Victoria Nicholas.
What did you say, Deb?
And this was from Victoria Nicholas at Takeda Pharmaceutical.
Okay. Hi, Victoria. Thank you for the question. Great question. I'll just start it. I'm pretty sure my colleagues will take over as well, which is great. But I guess for me, and I alluded to in this in my talk, is, and Janae said as well, I think Vincent said it as well, we cannot underestimate the power of those relationships pre-clinical trials. You have to, because it just goes so far to alleviate a lot of fears, a lot of the uncertainties, a lot of the trust that is built in, and got to remember that we are going against an institution of racism throughout the U.S. I mean, it's permeating through every aspect of our being, and so that interpersonal and real and raw relationship is so powerful to begin to chip away at some of those things. And I think the other thing is very much recognizing, which I alluded to earlier, is recognizing that you are on equal playing field. Because we all have things that are challenging for us. And just because you're dealing with the Black or Latino or, a marginalized group, it doesn't mean that they're less than. And so if you approach them with that idea that we're in this together, that also goes a long way. So anyone else who wants to, I don't know if to answer your question, Victoria, but if anyone else wants to jump on, feel free.
Thank you, Gigi. Vincent?
So, Gigi, it's very hard to follow you, just so you know. I would say, I would add this a tiny bit, though. I'd say one of the challenges with implicit bias is that it's implicit. A lot of times it's not in your awareness. And that is the biggest argument for diversity and inclusion. Because when you bring different people to the table, they have different perspectives. And oftentimes that can make visible things that are not obvious when a lot of people sitting at the table are a lot more similar than they are different. So I would say one of the things that you do want to do, which I mentioned a little bit in my talk, is make sure that you have some diversity and inclusion in your planning for all the work that you're doing and in every area of your execution as well.
Vicki, this is Dwayne. Thank you for that great question. And I hope the weather in LA is better than it is in Boston right now. I'm going to sort of respond to it maybe in a more concrete way. And I think that there are a lot of ways to manage this. And I know different entities have taken it on in different ways. I think group and facilitated processes are maybe a little superior to some of the others. Some will just offer readings. Some will offer access to websites like the Harvard Project Implicit Bias, the IAT. Some will often facilitate group discussions after readings. And I think that, multiple approaches I think are great. I think in some situations there may only be a self-study option, but I think getting groups of people together, and as Vincent had mentioned, having a diversity of experiences to share in those groups is probably the most effective way of getting started here.
And can I just quickly add to that, to piggyback off of what Vincent was saying and Dwayne as well, is that timing aspect. And I'm pretty sure that Janae can speak to this as well. Oftentimes, and also, Jen and Deb, oftentimes as NICU parents, we get asked to participate after everything has already been done. So it's almost like a, that furthers your your resistance to participate because it's like we're an afterthought. And so if you really want to show to parents that they are important and they are valued, it goes back to what Vincent said. You need to include them way ahead of time and at every aspect of it, because all too often, and it's happening now, and it happened a lot after George Floyd's death, we got asked things, but things had already been done. So it was like, well, what am I supposed to do? What am I actually contributing? How important is my voice, really?
And if I may, I think as a clinician, whether your clinical site has any research going on or not, I think all of us should be reminded again to look in the mirror and ask ourselves, where is our potential, bias that we don't think we have, right? I have many colleagues who say, oh, I'm not racist or I'm not biased against anybody. And it's not just a color issue. We had a Japanese family in one of our units, and she felt very similar thing that Gigi, you experienced. Because of the language barrier, cultural differences, people didn't talk to her at all, as often as her next door baby, whose mom was white. And nurses were more frequently visiting, frequently discussing things from A to Z, not necessarily about treatment or anything. So the Japanese mother texted me one day. I was the only lifeline to her in this unit. And she said, I don't think they respect me. So not just the color, but the cultural differences, language differences, all those things become a barrier. And evidence really shows that. So we have to just kind of step back and look at ourselves before clinical trials is discussed.
Very true. And the isolation factor, very isolating. I had many people tell me that after George Floyd died, that they had many people reach out to them and ask, what can I do? What can I do? And, and they got frustrated because they said, why am I telling you what to do? Why can't you why don't you find something to do? Why do I have to give you all the answers? And that was very enlightening. That was very enlightening. Okay, so we've got another question from Tamara Lewis, Children's Mercy, Kansas City. Do any of the speakers have ideas to address the apathy of academic medicine / research community around confronting racism as a cause of disparities? Would you like me to read that again?
Can I say something? As far as that goes, I have a lot of academic colleagues, not just in medicine, who are very apathetic about this issue. And I used to be one, actually. I'll be very honest, until several years ago. I didn't think most of us were biased, but there is a strong evidence of a disparity with infant mortality and various things. I think groups like Inc. or every societies like a NAN, National Association of Neonatal Nurses, we took up the disparity portion pretty prominently in our, keynote speaker. And this past week, I believe we who are leaders in associations and groups must prioritize on this topic very openly as something that means something to every one of us, not just some people. As long as we are not treating this matter as a priority, not in just this country, but globally, then we can convince people that it matters to many of us. Sorry, it's not a very intelligent solution, but.
It's all good. It's all good. Thank you, Wakako. Anyone else want to add to that? Did you want me to repeat the question? Everyone all at once? Going once? Going twice?
I would say that you can't change everybody, but you will find that for every individual who's either opposed or obviously agnostic as to the role that racism plays and how it impacts on our public health, there are several people who are quietly allied with the concern, but just don't know what to do. So what I would say is I wouldn't let that impede any effort to try to educate our colleagues around the issue. And that is sort of really understanding, starting with the basics, the definitions, talking about how it does have an impact, talking about the various issues, talking about the perspectives of families, as was shared here in this session, sharing readings, doing book clubs around these things. You'll find that you'll have support and allies in places where you never expected. And that's the low-hanging fruit, I would say. And ideally, your leadership is behind, these efforts. In our organization, our CEO circulated a video in which he stated, "Black Lives Matter," and that was heard throughout the organization. And you may follow that, you may not, but it's pretty clear what he thinks is important for our organization and where our organization should be focused and headed going forward. Leadership is really essential, I think, in having success in this area. And if your organization doesn't provide that, perhaps you can provide it within your own groups.
In addition to leadership being important, unfortunately, in our nation, we don't have equity or disparities or anti-racism or discrimination measures to hold ourselves accountable, to look at the allyship, to look at the empathy, to look at the rates of racial and ethnic disparities pre, during, and post-NICU reducing. And so it's really important for us as healthcare professionals and leaders and not to prioritize racial and health equity strategically and annually. Show me your strategic plan and show me your line item and show me your budget and show me your responsible department and your responsible leader that's going to be held accountable on a daily, weekly, monthly, and annual basis to addressing the pain points in your organization. And every organization knows their pain points. We can talk about it individually, we can talk about it collectively, but how are we going to hold ourselves accountable? Through our annual operating goals and procedures, through our incentives, right? Through our payment incentives, through the quality measures that we have to share back with JCAHO. And how are we going to participate in continuous and routine education and awareness and training? We can have conversations one-off by the cooler about things that we know that didn't work so well bedside with the family, and that set a family member off. And we can use those lessons and those teachings to elevate what we know need to happen and happen better so that we can move towards organizational transformation change that's lasting and sustaining.
Absolutely. And I think the key part of all that is it's not just a moment, it's a movement. Absolutely.
And also at the grassroots, I have become more, outspoken about bringing this discussion at the workplace with my colleagues or practitioners or nurses or physicians, because at the grassroots, we have to be doing something every day. And I actually notice some nurses treating certain patients differently or nurses treating each other differently. I've noticed those things over the years. I may spot those things a little bit more just because I wasn't used to that. So I've begun to speak about this in clinical places, and I get interesting responses. So I think I'm going to keep doing that. And I encourage all of us who can be at the grassroots to be open-minded and be prepared to be somewhat shocked about what you believe and what you don't believe, and be willing to be honest. That's something I recommend to all the people who are at the grassroots level in clinical settings where we are the interface with the parents or in the community. Thank you. I'm speaking too much now.
Well said. Well said. Thank you.
Janae, I love what you said, Janae, about being able to measure the work that's being done. And I'm wondering, how do we quantify that? Do you have any suggestions on how we could start doing that, not only in INC, but in every organization, the work that's being done?
Sure, Jen, thanks for that question. And I welcome others to join me in a response here. Every hospital is required to collect race, ethnicity, language, and social determinant of health data. How are we stratifying that data and applying it to our clinical measures and outcomes? How are we applying that data every time a family enters the NICU to say, are we offering adequate language services? Are we delivering services that are culturally unique and specific to the orientation in which the patient population is showing up in our care? As we're attempting to roll out clinical trials, what segments of the population and which geographies are we seeing, lower penetration or adoption rates based on these racial, ethnic, and social economic factors? And so we have access to high quality data that I think we need to move in the place and space of pairing off with PDSA cycles, plan, study, do, act cycles, and quality improvement cycles, and looking at stratifying these, leveraging this data to stratify patient satisfaction scores with as well, to say, where can we do better? We have the data. How are we using the data? And how will we use this to improve the quality of care or the quality of service that we're going to deliver to the population where we see and know we have the greatest pain points? I welcome others to join in the conversation, but we do have access to a good amount of data in our nation at the hospital, at the clinical, at the community level that we can leverage in a way that will help us reduce some of the racial and ethnic disparities that we face.
Thank you for that. Does anybody else want to add to that? I'm curious about what is going on in the clinical world and how these numbers are being used.
I don't know anything about this, so actually this is going to be a homework for me. I am going to ask one of the women's health director of nursing, about how they are analyzing by race and ethnicity all their response cards or response surveys from the parents at the Children's Hospital. I'm going to ask how they were analyzing that. I know they post those thank you notes, positive ones, but they really analyze the negative ones too. So that's my homework. I'm going to ask that. Does anybody know if that is being done by race, culture, ethnicity? That's a question.
That's a good question.
I think you'd find that if you've seen one data set, you've seen one data set, unfortunately. And in our own system of 14 hospitals, there were disparate categories for race and ethnicity. And we were a bit shocked by what we found in the ethnicity field. So one of the first things that we've done was to standardize a data set to ensure that we had the appropriate information. Another approach, because birth certificate information is self-identified, that offers another approach. If you can work with your state to have access to the birth certificate information that, in fact, your institution may be providing to the state, to provide a link between your family satisfaction data set and with these these identifiers that allow you to measure gaps rather than sort of total population. Vincent has years, more than a decade of information accumulated, and that offers an opportunity for a relook at how families are perceiving the support they receive, the information they receive, participation, the environment, and other factors that could be really informative. Where you thought that you were doing really well, you might find that there are many opportunities to improve. So I think that, you know, data, Janae made a really important point. Data is really important because if you're going to try to improve, you need to be able to demonstrate that you're improving. And the only way of doing that is with measurement.
Wonderful. So we actually have two more questions, and we've only got a few minutes, so I'm going to go very quickly. Jen, I'll go first. I'm curious if other countries struggle with inequities from racism and disparate care quality like the U.S. does.
How are things in England? Gigi, do you know?
A mess. Yes, they are. They are. It's different. I mean, because a lot of the inequalities. It's a lot of people of color come from the Caribbean, the various African countries. You know, a lot of the countries that were, you know, under the, you know, they're currently under Commonwealth. So it's similar, but it's a slightly different sort of take. And I think what happens a lot here that I see in both working in US and UK healthcare systems, there's a class divide as well, that really doesn't really matter what the color of your skin is. It depends on your postcode, where you are. And so when you have those two levels of inequality kind of come together, you get a whole load of, you know, all types of things that come out of it. So I think, generally speaking, yes, there inequality does exist within the, you know, the UK healthcare system, but it kind of it has another kind of underlying tone. I also do some work with a European group in Germany, and they also have discrimination, but not from color of your skin, again, from, you know, from your socioeconomic status. And so I think some of the things that we're talking about collecting data, and I think for me it'd be very important to collect the quantitative and qualitative data. And so that the type of information where it's not like numbers, but it's how people feel and their perception of things, because we know that perception is real. I mean, what people, even if they can't really pinpoint what's going on, if they're feeling it, it permeates their entire, you know, it colors whatever, however they interface with clinical trials. So, yeah, I don't know all the numbers, but I know just in working, you know, just kind of anecdotally in working in the system here, it definitely exists on different levels.
I can share about what's going on or what's not going on in Japan. I was just recently asked by a nursing association, and they asked me to speak specifically about diversity and disparity, just because right now Japan is only like a 2.25% foreign population is only 2.25% of the entire Japan. So just about everybody is Japanese in Japan. However, some foreigners are starting to live, and I have some NICU colleagues who are asking me questions about what do we do? 100% of the healthcare workers are all Japanese with black hair, black eyes, and we have Brazilian families, and so much differences are happening. So these same kind of a disparity will be recognized, and I believe that studies would probably pick up, research would pick up to analyze what's going on. Is there a disparity in outcomes? Because those studies have not been done. in many of the Asian nations, just because socioeconomic differences definitely exist too, but I've never seen studies that analyzed by certain levels what's the outcomes. So disparity is something the U.S. is definitely, I think, leading because there are more groups such as Vermont Oxford and Inc. Recognize this as priority. So I think it's a good trend for us to continue to lead so that other areas can follow.
Perfect. And we are going to end with that. We have more questions. We're going to actually follow up with them offline. Thank you, everyone. Tomorrow, the session starts at 10 a.m. Eastern Time. Thank you for joining us today. Have a great afternoon, evening, morning, and we'll see you tomorrow. Thank you.